Hello, my dear students and colleagues. Today we are going to discuss an important subject. It's called abortion, or sometimes we call it miscarriage. Let's agree on the term abortion. What does it mean? It means pregnancy loss before the fetal viability. Sometimes we mix up the word viable by the word living. The viable fetus is the fetus that's capable of surviving outside the uterus, not necessarily a living fetus. Let me explain this further. If we are having an 8 weeks fetus, is this fetus capable of living if it gets outside the uterus? Of course not. So it's not a viable fetus, although it may be living, having heartbeats. On the other hand, if we are having a 28 weeks fetus, is this fetus capable of living outside the uterus? The answer is yes. We may need an incubator, but this fetus can survive outside the uterus. What if this 28 weeks fetus is dead? It's still a viable fetus. So viable means capable of surviving outside the uterus. It does not mean it's living or dead. We may have a living but non-viable fetus or a viable but dead fetus. Is this common? Is abortion common? Yes, it happens in 10 to 15% of pregnancies. This means that 1 of every 10 to 1 of every 8 women who are going to get pregnant are going to lose their baby. This means that if we have 8 friends got pregnant together, one of them is not going to continue her current pregnancy. Is this common? Yes, this is a very high incidence. This is a common topic in obstetrics. Usually it happens early in pregnancy, before 8 weeks of gestation, and we're going to discuss later why. How does it present? It presents in different forms, but usually with vaginal bleeding and some sort of pain in most of the cases. If we classify abortion, we can classify it into spontaneous or induced. Spontaneous means it happened without any intervention. Induced means that we induced the abortion because of medical disorder to the mother that's going to harm her, so we induce the abortion or whatever it is. According to the clinical duration and the symptoms, we're going to tell a story now. It starts by threatened abortion that continues into inevitable, that continues into complete or incomplete, and sometimes a missed abortion. Let's explain this in more details. In Egypt, we describe abortion that it happens before 20 weeks because in Egypt, if the baby is born at 20 weeks with proper care and proper incubators, this baby is capable to survive, so this fetus is called viable. So spontaneous abortion that occurs before 20 weeks is called a spontaneous miscarriage. The types, I'd like to describe it as a story. Let's start with threatened miscarriage. What does it mean, threatened miscarriage? This lady is pregnant. In her early pregnancy, she experiences a little blood, not too much blood, a little blood, some colics. She goes to her doctor. We examine her. We find her pregnant. By the history, she's having a period of amenorrhea, and by examination, the cervix is closed, minimal vaginal bleeding. The size of the uterus corresponds to the period of amenorrhea, minimal pain. If we do an ultrasound, we find the fetus living we may see some little blood inside the uterus. Sometimes we don't see it, but the cervix is closed. This is called threatened abortion. Threatened means you have a threat that this baby may continue and may not. Most of the cases of threatened abortion continue to a normal pregnancy. Most of the cases continue to a normal pregnancy and she delivers at full term. However, sometimes after we prescribe her some medications, as we are going to explain later what's the treatment of threatened abortion, and we prescribe her rest, the pregnancy may not continue and the placental separation that was mild with mild bleeding increases and the placenta continues to separate more and more and more. The colics becomes more and more and more and the cervix is opened, or if it's a bigger fetus, the membranes may even rupture. So inevitably this baby is going to get out. The patient complains of more bleeding. It may be severe sometimes, and if we examine her, we'll find the cervix opened. If we do her an ultrasound, the baby may be still living, sometimes not, but maybe still living, but we cannot help her with that. The cervix is opened, too much contractions, this baby is going to get out soon. This is called inevitable. The word inevitable means it's going to happen anyway. During examination, we find the cervix opened. We may see the contents visible during a speculum examination. And with the ultrasound, we find the cervix opened, a big hematoma, blood inside the uterus. So what's the natural history of inevitable miscarriage? What if this lady came on a later stage? We will find either complete abortion or incomplete abortion. If all the contents came out, what will happen? The uterus will contract and the pain is going to subside. This will be called complete abortion. She comes with history of severe bleeding, then passage of the contents, then the pain subsided, minimal blood, cervix is starting to close again, uterine size becomes smaller, and this is complete abortion. However, sometimes we may find incomplete abortion. Incomplete abortion means that this lady experienced the passage of the fetus itself. However, some contents are still inside the uterus. The bleeding is still high and the colics are still there. And if we examine her, the cervix is still opened and the bleeding may be severe with incomplete abortion still. So this lady experienced threatened, that moved into inevitable, that moved into passage of some contents, and the rest are inside, so it's now called incomplete abortion. We can diagnose that with the history of passage of the contents. The uterus is still large, the cervix is still open, and by the ultrasound we find contents inside the uterus. While septic abortion, I'd like to explain that in details later on. Septic abortion means infection on any type of abortion. This will be called septic abortion. We're going to discuss that in details later. On the left side here, you can see the complete miscarriage that we discussed earlier, with the trunk cavities empty, the cervix starting to close, with the ultrasound, no contents. Let's get back again into the threatened abortion. This lady had an abnormal fetus. The fetus has some sort of chromosomal abnormality that we cannot discover by the ultrasound or by the history. in the first trimester. It's one of the very common causes of abortion, as we are going to explain later during this show. And we started treating this lady with progesterone, with some rest, and the bleeding stopped and the colics stopped because of the progesterone that we prescribed her. But then this baby could not continue. It died inside. This is called missed abortion. She's coming to check and she's happy about the bleeding that has stopped. However, we do her the ultrasound and we find no fetal cardiac activity. The baby has died. This is called missed abortion or missed miscarriage. This happens if the baby is small in size. Sometimes it happens with a bigger baby due to another cause, like antiphospholipid syndrome or like severe hypertension or so on, that we're going to describe later. And in such case, if the mother has started feeling the fetal kicks, she would notice no more fetal kicks and cessation of the symptoms of pregnancy. And now we do her the ultrasound, we find the baby is dead. Does she experience any bleeding? No. Does she experience any colics? No. By examination, the cervix is closed, so it's dead and retained, called missed abortion. On the left side here, we have a picture of threatened miscarriage, minimal bleeding, cervix is closed, inevitable in the middle, cervix is opened, severe bleeding. On the right side, incomplete miscarriage, passage of the fetus. We cannot see the fetus inside the uterus. However, the forming membranes and placenta are still inside, contents retained products of conception. POC stands for products of conception. Are still inside the uterus, so she's still experiencing bleeding and the cervix is still opened. Here again, on the upper left side, threatened abortion. Upper right side, inevitable abortion with open cervix and much bleeding. In the middle, we can see how does it look like when she expresses the passage of the contents. Lower left side, incomplete abortion, passage of the fetus while still the products of conception are inside, cervix is open, much bleeding as we see. If the baby dies and is retained, we see on the lower right side, missed abortion, no bleeding, no colics, the cervix is still closed. This is called missed abortion. In the middle, we have an ultrasound picture of complete abortion. The cavity is completely empty. What are the etiological factors and risk factors that may cause abortion? We can classify them into maternal factors and fetal factors. Something in the fetus, like chromosomal abnormality of the fetus, and this is the most common etiology in the miscarriage. Sometimes it's infection. Shall we classify this infection as maternal or fetal? It's maternal infection that passes to the fetus and causes fetal death, or maternal infection that causes the mother to be severely ill. So I prefer to use it as maternal instead of fetal infection because it usually starts in the mother. Maternal factors are high maternal age, because higher maternal age, as she approached the age of 40, she has more chromosomal abnormality feti. What's the relation between the abnormal chromosomes and abortion? Nature cleans itself. If we're having an abnormal chromosomal pattern of the fetus, this fetus does not produce proper enzymes for division, and it does not continue the pregnancy. This is called the natural selection theory. We say that nature cleans itself. If you're having a poor baby, this baby gets out. Endocrinological factors as severe endocrine disorder, diabetes, hypothyroidism, polycystic ovaries and luteal phase defect, where the progesterone that holds the baby inside during the first 12 weeks until the placenta is fully developed is poor. So the baby wants to stay inside, but no more progesterone or not enough progesterone to hold the baby inside. Sometimes the abnormality in the mother is in the uterus itself, abnormal shape of the uterus, or abnormal like bicornate uterus, or abnormal cavity, like if she's having a submucous fibroid, a fibroid inside the cavity of the uterus that causes the cavity to be distorted. Some infections, like we described earlier, that may cause the baby to die. Chemical agents, exposure to tobacco. Of course, we're talking about heavy cigarette smoking, not I just smelled the cigarette smoking yesterday, so I bought it today. No, we're talking about heavy cigarette smoking. Some intoxications by solvents, by some gases, but they have to be in good concentration. It's not that I smelled this pesticide yesterday, so I bought it today. No, it has to be in higher concentration. Some psychological disorders and some immunological disorders like the antiphospholipid syndrome and thrombophilia, where the blood flow to the fetus through the placenta, through the forming placenta, stops because of microthrombi that stop the blood flow through the placenta. Let's start with the fetal causes. The fetus is formed between an ovum that gets penetrated by sperm. If this ovum, during the meiotic division, has a lost chromosome or an extra chromosome, we're going to have an abnormal fetus with a 45 chromosome, means monosomy, or an extra chromosome. This is going to have 47 chromosomes, called trisomy. This fetus is incompatible with life unless some feti, like 45XO, the Turner syndrome, or the Mongol baby, the Down syndrome, with triple 21 chromosomes. Such cases are compatible with life, but other chromosomes usually are incompatible with life. Other times we have polyploidy. What do we mean by polyploidy? That the fetus is formed by the union between an egg and the sperm. And when the sperm enters, the egg produces a blocking antibody that prevents further sperms from penetration. If this doesn't happen, 2 sperms, 3 sperms, or whatever enter inside the egg, and we call this polyploidy. Sometimes we have a chromosome translocated into another part. If this is balanced carrier, the baby may be living. But when it's an unbalanced carrier, too few copies of a certain gene or too many copies of a certain gene, this will cause this embryo to be incompatible with life, and it ends with an abortion. Then comes the fetal infection. Shall we classify it as maternal cause or fetal cause? You can do this and you can do that. I usually prefer to classify them as maternal rather than fetus, although the fetus got infected, but the origin is from the mother, like Listeria monocytogenes, like cytomegalovirus, like herpes simplex, usually the primary infection. The primary infection, which means that the mother got infected for the first time during pregnancy. Very, very, very rare with secondary or reactivation of infection. Sometimes it happens with the so famous toxoplasma, so famous here in Egypt, in the minds of maternal of the mothers in Egypt. Toxoplasma is transmitted through uncooked beef, uncooked meat, uncooked beef, and the stools of domestic animals that feed on uncooked beef. What about the maternal causes? The maternal causes may be locally in the uterus, as we described before. The cavity of the uterus is not suitable to receive a baby, like if we're having a uterine septum, a long big uterine septum as we see on the left side, or submucous fibroid that's present at the part where the placenta is going to get attached, so the placenta cannot bury itself properly and form the chorionic villi because of the presence of this submucous myoma, and this may cause an abortion. Other maternal causes are maternal diseases like obesity. This may cause luteal phase defect as well, by the way. Endocrine disorders like diabetes mellitus, if it's uncontrolled, if the diabetes mellitus is controlled, this is not going to cause abortion. Thyroid dysfunction, again, uncontrolled thyroid dysfunction. Polycystic ovary, through the formation of luteal phase defect, as we explained earlier. Some immunological disorders, the antiphospholipid syndrome, either alone or within systemic lupus erythematosus. This causes microthrombi, micro blood clots, that are going to stop the blood flow through the placenta to the fetus and may cause fetal death. Exposure to teratogens, either drugs, either medications, either a high amount of alcohol or cigarette smoking or substance abuse, this may cause birth defect or fetal death early in the embryonic period between 3 and 8 weeks. What are the risk factors for for pregnancy loss? Increased maternal age, because this may cause higher incidence of chromosomal abnormal fetus. Multiparity with weak endometrium. Previous and recurrent pregnancy loss. Sometimes we don't find any reason. It's called unexplained pregnancy loss. We're going to discuss this later in the recurrent pregnancy loss. But if we don't find a cause for the recurrent pregnancy loss, it's going to happen again, maybe. Heavy smoking, regular alcohol intake or substance intake. This is going to cause abortion again and again. Psychological stress and domestic violence. Infections, like we described earlier. If she's having an infection, she's going to get pregnant again. She's still having the infection. The mother is still having an infection. She's going to abort again. Medical disorders like uncontrolled diabetes or systemic lupus erythematosus. She's going to get pregnant again with uncontrolled diabetes again. She's going to abort again. Morbid maternal obesity, again, is a factor. The clinical presentation and investigations. When it happens, the threatened abortion, small amount of vaginal bleeding, without passage of contents. If the contents pass completely, it's complete. Incompletely, it's incomplete. Further along, we find lower abdominal pain, increased vaginal bleeding, passage of the fetus. What are we going to see by the ultrasound? Like we described earlier, in threatened abortion, the fetus is living inside. In inevitable abortion, much bleeding with an open cervix versus closed cervix in threatened abortion. In incomplete abortion, contents are still there, the cervix is open. In complete abortion, no more contents inside the uterus. In missed abortion, the baby is dead. Let's see. Here we have the endometrial cavity with products of conception here. So if we're having products of conception and we don't see the fetus, this is called incomplete abortion. While here we have an empty sac, the baby died at a very small age that we cannot even see it by the ultrasound. This is called an embryonic sac, which is a form of missed abortion. Here we have again retained products of conception, here and here, the white thing. The darker shade of gray here is the uterine wall itself. The lighter shade of gray here are the contents. This is called incomplete abortion. The black thing here is blood with some shaggy contents here. This is incomplete abortion. Can we see a fetus? No, we can't. So is this complete or incomplete? We have contents here, we have contents here. This is incomplete abortion. Missed abortion, no fetal pulsations. Fetus with no fetal pulsations. Of course, you cannot see the fetal pulsations with a standstill picture like this. The ultrasound has to be a real-time ultrasound. Real-time ultrasound means you have to see it a moving picture. If I get you a picture like this one, and I tell you, is this baby living or dead, you cannot say. I have to tell you that there are no fetal pulsations, because you won't know if there are some pulsations or not by a static picture like this. The ultrasound has to be a real-time ultrasound picture. What do we have here? Again, empty sac, empty sac. This is missed abortion. A subtitle of missed abortion called an embryonic pregnancy or blighted ovum. What are the complications of abortion? If she bleeds much, she's going to go into hypovolemic shock, hemorrhagic shock. While infection on any type of abortion that we described earlier as septic abortion may cause septic endometritis, and she's not going to be able to get pregnant again easily. Salpingitis with tubal block and infertility, or even peritonitis, which is a very serious complication. If the infection in septic abortion spreads to the blood, it causes septicemia. This may cause septic shock, disseminated intravascular coagulopathy and renal failure, and sometimes it may cause death. Complications of the surgical procedure to evacuate the uterus, as we are going to describe shortly, are uterine perforation and subsequent intestinal injury. How to manage spontaneous abortion? If we are facing a woman with threatened abortion means a little blood, little colics, closed cervix, baby is living. Just reassure her that she's going to continue her pregnancy until full term in most of the cases. Rest, complete physical and mental rest. Physical rest means physical rest, not necessarily lying flat in bed, but physical rest means she should not perform any physical exercise or any physical duties. I usually tell her, you're like a guest in the house. A guest can go sitting here, sitting there, sleeping here, sleeping there, but no physical activity, and mental rest by reassurance. Progesterone support will help to maintain this pregnancy until the first trimester is complete and the placenta is formed to start forming its own progesterone. If it passes into inevitable or incomplete abortion, both are the same. When the bleeding is excessive or contents are considerable, we do the surgical evacuation. If this lady is below 12 weeks, surgical evacuation means we evacuate the contents of the uterus by surgical procedure through the cervix, either by suction or by a spoon, a special spoon called the carotid spoon, through the cervix if it's below 12 weeks. While if the bleeding is mild and the contents are minimal, we may perform medical evacuation instead of surgical evacuation by giving the woman misoprostol, which are some tablets that cause the uterus to contract and expel the contents, and then we give her ergometrin that continues the process of expulsion. With inevitable abortion, if the bleeding is severe, we have to give her anti-shock measures, we have to admit her to the hospital and terminate, as we explained earlier. This goes for both inevitable and incomplete abortion. What about missed abortion? Missed abortion is not that serious. We can wait for a few weeks for spontaneous expulsion if the bleeding is minimal or no vaginal bleeding. But the woman has to be reassured that no complications are going to happen to her. Usually, we may wait for up to 4 weeks until this happens. If the mother is anxious, then we proceed further into curettage, surgical evacuation before 12 weeks, hysterotomy after the first trimester, during the second trimester, if the medical or treatment failed. Medical treatment is usually used in the first and second trimester with intrauterine fetal death. If the mother is non-sensitized, remember to give her the anti-D immunoglobulin if she is Rh negative. Then we come to explain what is septic abortion. Septic abortion is any type of abortion with superimposed infection. Usually it happens with group B streptococci, staphylococci, E. coli, or Clostridium mulci. Usually this happens when the mother performs some sort of evacuation with non-sterile procedure, and the doctor uses non-sterile or non-properly sterile instruments. So infection happens inside the uterus, or sometimes it happens with incomplete abortion, but the bleeding is minimal, so the mother does not seek proper medical advice, and she starts to have group B streptococci, which grows in the vagina of the mother, that goes into the uterus on the contents, and she experiences septic abortion. It may be superimposed on incomplete abortion, missed abortion, with fever, high fever, offensive discharge, abdominal pain. She may experience the complications of septic shock or septicemia. When we come to examine her, we find soft, tender, subinvoluted uterus. The ultrasound shows products of conception. How do we know that this is septic abortion? Increased total leukocytic count with shift to the left and toxic granulations. Elevated ESR and C-reactive protein, which show that she's having infection inside. How to treat her? Can we evacuate her now? No, the uterus is soft, tender, and subinvoluted, is going to be perforated. And what's more important, that we have to start broad-spectrum antibiotic and ecbolics to regain the uterine tone before we start the evacuation gently, gentle curettage under umbrella of antibiotics, or else she will go into perforation and septicemia. What about recurrent pregnancy loss? Recurrent pregnancy loss means 3 successive spontaneous abortions without intervention. 3 successive spontaneous abortions without intervention and without a term pregnancy in between, of course. This is called successive abortion. Okay. Was previously called habitual abortion. Is this common? Not very much common. Not like the spontaneous single abortion. It affects around 2%. It's still not a small figure, by the way. 2% means 2 of every 100, 1 of every 50. This is still high. Mostly it occurs in the first trimester. Sometimes with incompetent cervix it occurs later in the second trimester, as we are going to describe. What are the causes of recurrent abortion? Like we explained earlier, sometimes it's genetic. The mother or the father is having some genetic disorder that passes to the fetus. Hormonal, the mother is having abnormal hormonal milieu like uncontrolled diabetes, uncontrolled thyroid dysfunction. Anatomical, with septum inside the uterus, fibroid inside the uterus, submucous myoma, weak cervix. Environmental hazard, immunological like antiphospholipid syndrome. Let's see that in more details. Chromosomal factors. Chromosomal factors are usually, as we described earlier, trisomies, aneuploidies, abnormal meiotic division, or polyploidy, aneuploidy, and trisomies. Other maternal factors like the luteal phase defect that's going to stay there every time she gets pregnant. She's having luteal phase defect. Progesterone is little, does not support the fetus properly during the first trimester, so she aborts. Endocrinal abnormalities are the same. Bicornate uterus, submucous myoma, so the placenta, when it comes to attach to the uterus, it cannot perforate properly into the endometrium to form the chorionic villi. No more blood reaches the fetus, she aborts. The same happens when the placenta gets attached to the septum with poor blood supply. Incompetent cervix that we're going to describe in full details. Of course, chromosomal abortion happens in the first trimester of pregnancy, while other factors may occur later in pregnancy. How to evaluate cases with recurrent pregnancy loss? With the history, we find the history of menorrhagia if she's having a fibroid or a uterine septum. She's having a history of uncontrolled diabetes, a history of maternal intoxication, environmental factor, thyroid dysfunction, etc., etc. By manual pelvic examination, we may find the uterus bigger in cases of fibroid uterus. We might find a broad uterus in cases of bicornate uterus or broad septum. Transvaginal ultrasound will show us the myoma inside the uterus and the septum. Hysteroscopy may show intrauterine synecdoche, may show the myoma, may show the septum. Chromosomal karyotyping for both parents and the products of conception sometimes may reveal the abnormal chromosomal pattern that causes the recurrent abortion. Lab tests and screening tests, we may find infection, maternal infection that may cause recurrent abortion. We may find antiphospholipid syndrome. How to diagnose, how to treat. If it's genetic, we do the genetic karyotyping for both partners and for the products of conception. How to treat genetic counseling. We tell them what's the ratio of getting a poor baby, and then we proceed an IVF procedure. And before we do the implantation, before we do the embryo transfer, we do a genetic diagnosis to see which feti are normal and which are abnormal, and we only transfer the normal feti. Donor gametes are not accepted in Egypt, neither legal. Immunological factors like lupus anticoagulant and antiphospholipid syndrome, and we treat that with medications that prevent the microthrombi that we explained earlier from forming, like aspirin in a small dose or heparin, low molecular weight heparin, with or without aspirin. If we're having an abnormal endocrinological factor, we treat it. She's having luteal phase defect, poor progesterone, we give her progesterone. She's having abnormal thyroid function, hypothyroidism, we give her thyroxine. She's having high prolactin that causes luteal phase defect, we lower the prolactin by bromocriptine. She's having high blood sugar, hemoglobin A1C is high, we control her blood sugar. If she's having psychological problem, we give her some support group and some medications to control the psychological issue that she's having. She should stop taking alcohol or maternal exposure to toxins and chemicals. She should stop smoking. If we're having anatomical factor like septum that we can see with the ultrasound, with histogram, with hysteroscopy, with sonohysterography, we remove the septum, we remove the myoma, we do lysis for the adhesions via hysteroscopy. Here we can see that do the blood screening tests, do the histogram, do the karyotyping. Management with recurrent pregnancy loss is treatment of the underlying cause. Whatever the cause is, treated. So the key point in treating recurrent pregnancy loss is diagnosis, proper diagnosis. Why did she abort? Once you discover why did she abort, you can treat her. Like we say, drug prescription is a monkey's business. Anybody can prescribe a medication once you give him the proper diagnosis. So your role as a good, clever doctor is to reach the proper etiology. However, some 30% of the cases you find no etiology. Several types of treatment have been tried for that. It's called empirical treatment. We performed a lot of studies to see which treatment is more effective. Shall we give her folic acid? Shall we give her progesterone? Shall we give her aspirin in small doses? Low molecular weight heparin, corticosteroids? Several studies have been implemented, and the most common thing is that we give is progesterone with the most accepted, with the highest accepted results, progesterone, and sometimes baby aspirin as well, small doses of aspirin. What about the cervical insufficiency? Incompetent cervix. Incompetent cervix means that the uterine cervix cannot hold the baby inside during the second trimester of pregnancy without contractions. Let me explain that in more details. During the first trimester of pregnancy, the baby has no weight. It weighs very few grams, and it holds no pressure and no weight on the cervix. Some women have weak cervices. If this woman is having a weak cervix, a weak cervical muscle, what's going to happen in the second trimester of pregnancy, when the baby gets bigger and gets heavier, and it starts to exert some pressure on the cervix cannot hold it. So she experiences pelvic heaviness. She calls her doctor, and she's on her way to her doctor. She experiences passage of the baby from the cervix without contractions. She did not go into labor. She did not go into contractions. It's just the weight of the baby on the cervix that's weak caused this cervix to be incompetent. Weak caused the cervix not to hold the baby, so the baby fell out of her. Second trimester. Why second trimester, not first trimester? Because during the first trimester the baby weighs very few grams and it does not exert any weight on the cervix. Second trimester, the baby exerts some weight. So recurrent abortion, second trimester of pregnancy, painless, without contractions, spontaneously. It's quite uncommon, 2 in every 1,000. Why would she have a weak cervix? Sometimes it's congenital. We find it with septated bicornuate uterus, or acquired like she's having previous cervical trauma, laceration from excessive cervical dilatation, or conization. Sometimes she's having fibroid polyps inside the cervix. Multifetal pregnancy where the uterus is so much stretched, so the cervix is stretched as well. And like we have just described, one or more mid-trimester abortion. Sudden onset, painless course. Again, to describe a clinical history of incompetent cervix, the patient did not go into labor. She did not go into contraction that lasted for 6 hours, ended by mid-trimester abortion. This is not the history of incompetent cervix. Incompetent cervix is painless. The cervix could not hold the fetus inside. The signs: the cervix may admit a tip of finger, the membranes occasionally protruding. Like here we put a speculum. We see the anterior cervical lip, the posterior cervical lip, and we can see the membranes here. Opened, dilated cervix. Okay. If we don't catch this mother now with a repair for this dilated cervix by an operation, she's going to go into abortion. How to treat that? With an operation called cerclage, where we insert a tape formed of a strong non-absorbable material that we put a circle around the cervix to close the cervix after we push the herniated amniotic sac inside, or even before it comes outside. This is called cerclage because we perform a circle around the cervix. The ultrasound diagnosis, as we see, the normal cervix looks like a T. The cervix looks like a Y. The cervix looks like a V, more opened. More and more opened, it looks like a U. So this is the normal cervix, a T, and starts to open, to open, and to open. These are the incompetent cervices. Here we measure the length of the cervix, long cervix, closed T-shaped cervix, while here we have the V-shaped cervix and short cervix. Again, Here we have the T-shaped cervix, closed T. Here we have a Y-shaped cervix. Again, here we have a V-shaped cervix, while here we have a more open U-shaped cervix. The procedure is called the cerclage operation for rhythmic incompetence or cervical incompetence. We perform it through the vagina, transvaginal, regular transvaginal, or high transvaginal, or transabdominal, even in some cases if we don't find any cervix or with high cervical laceration. This is very rare, by the way. The transabdominal is very rare procedure. We use the non-absorbable strong tape called Mersilene tape. You find the tape here, the needle on this side and needle on this side. The needle we use is semicircular needle like this. You hold the cervix with one end, you go, this is why it's semicircular, you go pinch here, a pinch here, then you go pinch here, then you go pinch here, then you go a pinch here. Once you pull this, it's going to close the cervix. It's a purse string. It's like if you're having this old purse of money that's used to be closed by a purse string like this. This is why it's called a purse string suture. This is called McDonald's operation. Here we have suture after we do the purse string suture. You may put it on the front lip, or if you're having two needles on the Mersilene tape like we saw, we put it on the posterior lip. This is the McDonald's operation again. While there is another type where you open the vagina higher up to put it high up, high vagina, open the vagina, you go with your tape to surround the cervix, submucosal, you go out again here, you close the mucosa, up and anterior and posterior, you pull it. It's called Shirodkar operation. This is more efficient because it's higher. It's put on a higher level, but it's more difficult and it causes more bleeding because you open the vagina here, open this the mucosa here, you open the mucosa here, you go surround the cervix. We perform the Shirodkar operation when we have cervical lacerations that we cannot perform the McDonald, the previously described operation. Transabdominal, when you don't have any cervix to close from down there, excessive cervical lacerations, that you don't find any proper cervix to do McDonald's or Shirodkar operation. So you open the belly, you open the abdomen, you go through the abdominal cavity, through the peritoneal cavity, you dissect the peritoneum, and you perform the cerclage by the Mersilene tape or Mersilene band around the upper part of the isthmus, as you can see here. It's quite a difficult operation, and of course you close the belly again. This lady cannot deliver vaginally. The Shirodkar and the McDonald's operation, you remove the stitch vaginally, and this lady may deliver vaginally later on. You remove the stitch vaginally by 36 to 37 weeks, and the lady can deliver vaginally. And even if she gets into labor before that, or you haven't removed the stitch yet, you can remove the stitch during the first stage of labor, early first stage of labor, before the cervix lacerates. But the transabdominal cerclage, you have to do a C-section, Of course, you're not going to open the abdomen again to remove the cerclage, then close the abdomen, then deliver her vaginally. We're going to open the abdomen and do a C-section. These are some pics of the transabdominal cerclage. In summary, pregnancy loss is loss of the pregnancy before fetal viability or 20 weeks, like we described what is the age of viability. Risk factors are chromosomal abnormalities, teratogens, high maternal age, uterine abnormalities, autoimmune disorders, and severe trauma. Describe different types: what's threatened abortion, minimal bleeding, closed cervix. Usually it continues with reassurance, rest, and progesterone. Inevitable, severe bleeding, severe colics, cervix is opened, IV fluid, give her blood and shock measures. It ends up by a medical evacuation if the bleeding is not that much, or surgical evacuation, give her the anti-D if she's Rh negative. It completes into incomplete abortion, same bleeding, high bleeding, open cervix, but the ultrasound shows retained products with no fetus, like above. Complete abortion, everything has passed, the bleeding becomes less, cervix becomes closed, no further treatment is required. Missed abortion, retained dead fetus with no bleeding, cervix closed. You can wait for up to 4 weeks, and then you do her the surgical evacuation if it's before 12 weeks, or medical evacuation if it's higher than that. The only complication that you may face in such a condition is DIC if the baby is of higher gestational age, or infection. So if you're going to wait for the 4 weeks, you have to watch for coagulation profile, and you have to check she's not having intrauterine infection. Septic abortion, like we explained earlier, is infection upon any type of pregnancy that may complicate with septicemia, septic shock, renal failure, DIC, up to death. Do not evacuate the lady except after a good umbrella of broad-spectrum antibiotics or according to cultural sensitivity, and give her ecbolics to regain the uterine tone to avoid perforation. Recurrent abortion are 3 consecutive successive miscarriages. Usually it happens in the first trimester, second trimester, think of incompetent cervix. These are the pictures of different types of abortion, of cerclage operation. Hope you enjoyed the show, and good luck.